The global pandemic before COVID-19, the most important disease of the 90s. Today we're going to be talking about HIV/AIDS. This is Dr. Ignatius Cole. Welcome to Dr. Ignatius Cole's medical tutorial, and today we'll be talking about HIV and AIDS. Let's go. So about the presentation, we'll be talking about the differences between HIV1 and HIV2, the epidemiology, the transmission of HIV, the structure of HIV, the pathogenesis, the investigation, the clinical staging given by WHO, the prevention of opportunistic infection, antiretroviral therapy, and post-exposure prophylaxis. So buckle up. So what are the differences between HIV1 and HIV2? Well, the one we are going to be talking about and the one that has caused pandemic is HIV1. It originated from chimpanzees and it is more transmissible than HIV2. HIV2 is restricted to Western Africa, originated from sooty Mangabey monkeys, and is less transmissible and progresses more slowly. So in 2015, there were 36.7 million people living with HIV, 2.1 million new infections were recorded, 1.1 million AIDS-related deaths were recorded, and total number of people using ART reached up to 17 million. So how is HIV transmitted? We all know that HIV is transmitted through unprotected sexual intercourse with HIV-infected partner. However, it can be also transmitted from an infected to mother to child through breastfeeding or through delivery itself. It can be transmitted when people share needles with infected person, when there is blood transfusion or organ transplant from an infected person, or there is tattoo or body piercing with unsterilized needles. So risks of HIV transmission after single exposure to an HIV infected source. So we can see that even in vaginal intercourse, the risk of transmission is more from male to female than from female to male. And the overall percentage after single exposure is actually very low. But the transmission is very high after a single episode of blood transfusion, reaching 90%. And after vaginal delivery, reaching 15%. Other approximate risks from other method of transmission are given here. You can pause it and see it. So talking about the structure of HIV, there are glycoproteins on its outermost layer, envelope. In this envelope, there are glycoproteins, glycoprotein 120, GP120, and GP41. Inside the viral capsid, there are nuclear capsid, and there is viral RNA genome, TAT enzyme. The virus also contains other enzymes like integrase to integrate with the host DNA, reverse transcriptase, which converts RNA into DNA, and protease enzyme. And the outermost layer is the lipid membrane, and inside it there is the matrix protein, and inside it there is a capsid. So this is the viral structure in just brief. So this is the HIV virion. When it reaches immune cells like the dendritic cells or the CD4 helper T cells which have CD4 receptor, it primarily attaches to the CD4 receptor, and then it binds to the co-receptor, which is usually CCR5 or CXCR4. They are the chemokines co-receptor. So it has bound to the CD4 receptor and is binding to the chemokine co-receptor. It binds to the CD4 receptor, it rolls, and it binds, stabilizes to the chemokine co-receptor. One funny thing about the CCR5 or CXCR4 is people who don't have CCR5 or CXCR4 or have strange mutation in them are very less liable to suffer from HIV or don't suffer from HIV at all. The HIV virus is ineffective towards them. And then it will fuse with the cell. The virus will fuse with the cell. So talking about the drugs, we'll talk about the drugs later. So when the virus fuses with the cell, it releases its viral genome, which is RNA. And the reverse transcriptase enzyme will convert the viral RNA into double-stranded DNA. And the double-stranded DNA will be integrated into the host DNA as a proviral DNA. And this proviral DNA can remain in the CD4 plus T cells for years. In the latent phase, the proviral DNA remains in the CD4 T cells, and as the helper T cells multiply, the virus also multiplies, but it does not do anything, it does not do any damage. And when it gets the chance, it will cause transcription. During transcription, it will express its viral mRNA, it will send out its messenger RNA, and will cause the synthesis of viral proteins, and it will cause the formation of virus, and numerous virus will be released at the expense of the helper T cells. This way the helper T cells will be depleted. So during these stages there are many drugs, the antiretroviral drugs, which will function. So chemokine receptor antagonists, the newer drugs like maraviroc, will inhibit the chemokine co-receptor CCR5 or CXCR4. The fusion inhibitors will inhibit the fusion of virus with the host cell. The reverse transcriptase inhibitors, which are usually used nowadays like NRTI and NNRTI, the nucleosidase reverse transcriptase inhibitor or the non-nucleoside reverse transcriptase inhibitor, will inhibit the reverse transcription. And the integrase inhibitor like raltegravir will inhibit the integration or the integrase enzyme. And some protease inhibitors, PI, will inhibit the cleavage of polypeptides and assembly to form the new virus. So this is the pathogenesis of the virus itself and the mechanism of action of the antiretroviral drugs. You can pause this slide, take a screenshot, and study it in more detail. So what are the investigations? So first of all, when we get a patient who we suspect of having HIV/AIDS, we will have to find out whether he has HIV/AIDS or not. For that purpose, we can detect the host antibodies by ELISA or Western blot. Western blot being more confirmatory. We can also detect the P24 antigen of the virus. We can use nucleic acid amplification test, NAAT, usually polymerase chain reaction, to detect the HIV RNA. And this HIV RNA are used primarily to diagnose infection in infants of HIV infected mothers, because these infants of HIV infected mothers will have maternal antibodies. So ELISA and Western blot is positive in every infant born to HIV infected mothers, but the NAAT or PCR may be negative, and this can determine primary infection. Also, it can determine HIV in the infants born to HIV infected mother, and it can determine primary infection where there are no antibodies. So NAAT or PCR can also be used in infants up to 15 months of age born to HIV infected mothers and to diagnose the primary infection. So once we are sure that the person has HIV, we have to do other tests like CD4 count to see how far has the disease progressed, the viral load to find out the efficacy of the ART, and to see how bad the case is, the SBS-AG and the hepatitis C antibody, liver function test to detect other STIs, full blood count, urine analysis and serum creatinine, syphilis serology, cervical smear in women, serum cryptococcal antigen, this is to detect the human papilloma virus and to detect cervical CA if it is present, tuberculin skin test because tuberculosis can occur, and STI screen, so we need to test for other STI too. So the normal CD4 count is over 500 cells per millimeter cube. People with CD4 counts between 200 and 500 cells per millimeter cube have a low risk of developing opportunistic infection. And as the CD4 counts decline, opportunistic infection like this given here become more prominent. And once the CD4 count is below 200 cells per millimeter cube, this is the cutoff point, there is severe immune suppression and high risk of AIDS defining condition. And so the CD4 count should be performed every 3 to 6 months in patients on antiretroviral therapy, together with the measurement of viral load. So talking about the viral load, the level of viremia is measured by quantitative PCR. We're talking about quantitative PCR of HIV RNA. So we'll measure the number of HIV RNA, the number of HIV virus present. So when people have high viral loads like more than 100,000 copies per milliliter, they will experience rapid decline in CD4 count compared to those people with low viral loads like less than 1,000 copies per milliliter, who will have slow or even no decline in CD4 counts. So this is the graph which will show how the infection proceeds. There will be primary infection in the first time, and then HIV will travel to different organs. It will seed the lymphoid organs. It will be disseminated, and in the lymphoid organs, it will stay latent for many years. So viral count load will increase instantly for some time, and it will be constant for a long time. But the CD4 count will decrease initially for a short time. It will increase again and will stabilize and decrease and decrease and decrease and will become very low. So this is the graph, this is the latent period, and this is the time where AIDS occur, which is the immunodeficiency stage. So what are the features of primary infection? It is very difficult to diagnose primary infection because 50% of people will be asymptomatic during the primary infection. The others will have fever, maculopapular rash, pharyngitis, lymphadenopathy, myalgia, arthralgia, diarrhea, headache, oral or genital ulceration, meningoencephalitis, and Bell's palsy. So these features usually resemble infectious mononucleosis. So these are the CD4 count and risks of common HIV-associated disease. When the CD4 count decreases, the risks of other many diseases become very high. Rather than I speaking out for you, you can pause it and see it. The main important are when it is less than 500, the chances of tuberculosis, bacterial pneumonia, oropharyngeal candidiasis, non-Hodgkin lymphoma, and Kaposi sarcoma become high. Below 200 cells per millimeter cube, pneumocystis jirovecii pneumonia, herpes simplex ulcer, and other diseases become high. Esophageal candidiasis become high, and below 100 cells per millimeter cube, cerebral toxoplasmosis, cryptococcal meningitis, this opportunistic infection become high. The risk of this opportunistic infection will become very high. So clinical staging of AIDS. So in stage 1, the person is usually asymptomatic and there is persistent generalized lymphadenopathy. On stage 2, there is unexplained moderate weight loss, which is less than 10% of body weight, and there is herpes zoster, recurrent URTI, and there can be fungal nail infection, etc. In stage 3, there is unexplained or severe weight loss, more than 10% of body weight, unexplained chronic diarrhea for more than 1 month, and unexplained persistent fever more than 37.5 degrees Celsius for 1 month. So if these 3 features are present, suspect HIV/AIDS. Severe weight loss, chronic diarrhea, and persistent fever, diarrhea and fever for 1 month, and if there is severe weight loss, you can always suspect AIDS. And there are also oral candidiasis, pulmonary tuberculosis, and there is granulocytopenia or pancytopenia. There is anemia plus neutropenia plus thrombocytopenia. All 3 are present in stage 3. And there can be also dental conditions like ANUZ or periodontitis. On stage 4, many opportunistic infections occur like candidiasis of esophagus, trachea, bronchi, lungs. There can be cryptosporidiosis, cryptococcosis, and other cerebral toxoplasmosis, extrapulmonary tuberculosis, pneumocystis pneumonia, lymphoma, Kaposi sarcoma, cystoisosporiasis, and many other conditions, lymphoma, etc. So how do we treat HIV? It's the main focus when the person has suffered from AIDS or immunodeficiency is that we have to prevent opportunistic infection like we mentioned earlier. So what drugs do we prescribe? We have to give cotrimoxazole primary prophylaxis. Since tuberculosis is a main concern, we can give tuberculosis preventative therapy. We can prevent Mycobacterium avium complex. We have to prevent cryptococcosis, and we have to give several immunizations. So what are the indications for cotrimoxazole primary prophylaxis? They are clinical evidence of immune suppression. The patient is in WHO stage 3 or 4. A laboratory evidence of immune suppression. CD4 count less than 200 cells per millimeter cube. Recommended dose is 960 mg daily. Side effects can be hypersensitivity, maculopapular rash, and neutropenia. If cotrimoxazole is not tolerated, we can use dapsone. And cotrimoxazole is a very useful drug in cases of AIDS. It can prevent pneumocystis jirovecii pneumonia, cerebral toxoplasmosis, bacterial pneumonia, bacteremia, cystoisosporiasis, and malaria. Another concern is tuberculosis. So to prevent tuberculosis, we can start with isoniazid or a combination of rifamycin and isoniazid. And this will reduce the risk of tuberculosis in patients with positive tuberculosis skin test. But we have to confirm that the person is not tuberculosis positive already. He is not suffering from tuberculosis already. So the usual guideline is rifampicin or rifampicin with isoniazid for 12 weeks is as effective as 6 to 12 months of isoniazid. And to be sure that there is no tuberculosis before we start the preventative therapy, we have to exclude the four symptoms: active cough, weight loss, night sweats, and fever. What about Mycobacterium avium complex? In high-income countries, a macrolide like azithromycin or clarithromycin is recommended to prevent MSC in those with CD4 count below 50 cells per millimeter cube, and this therapy can be discontinued once the CD4 count has risen to over 100 cells per millimeter cube. But in poor countries, this is not needed. And cryptococcosis is out of the concern. If serum cryptococcal antigen is positive and CD4 count is less than 100 cells per millimeter cube, we have to prevent cryptococcosis actively by giving fluconazole. What about immunization? We know that live viruses are actually contraindicated in HIV/AIDS, and immune responses to vaccination are also impaired in HIV-infected patients. So if CD4 count is below 200 cells per millimeter cube, we do not give suggestion for immunization. But all patients should be given conjugate pneumococcal vaccine and annual influenza vaccination, PCV, and flu shots, hepatitis B vaccination if they need it, hepatitis A in those at risk, human papillomavirus in people less than 40 years, measles, mumps, rubella, MMR in those with negative measles serology, meningococcus in people less than 25 years old, those with acyclinemia or complement deficiency, and during outbreaks, and DTaP, diphtheria, tetanus, and acellular pertussis or inactivated poliovirus vaccine for those who made the general indication for these vaccines. And chickenpox can also be given if the person is seronegative. So these all vaccines can be given if the person needs it, if he meets the criteria. So the main treatment of HIV/AIDS is the antiretroviral therapy. WHO has proposed a new rule, antiretroviral therapy, for all of the patients suffering from HIV. So the goals of the ART are to reduce the viral load to an undetectable level for as long as possible, to improve the CD4 count to over 200 cells per millimeter cube, so to increase the CD4 count, to reduce the viral load, to improve the quality of life without drug toxicity, and reduce the transmission. So coming to the commonly used antiretroviral drugs, they are nucleoside reverse transcriptase inhibitors like abacavir, amitriptyline, lamivudine, tenofovir, and zidovudine. Non-nucleoside reverse transcriptase inhibitors are NNRTIs like efavirenz and rilvegevir. So rilvegevir is used only if viral load is less than 100,000. Protease inhibitors like atazanavir, darunavir, and lopinavir. Integrase inhibitors like raltegravir, dolutegravir, elvitegravir. Chemokine receptor inhibitors like maraviroc. We already discussed the mechanism of action earlier in this video. And drugs like zidovudine, efavirenz, lopinavir are no longer recommended as first-line options in high-income countries. So how do we prescribe these drugs? There are so many drugs to choose from, but usually we give 2 NRTIs, nucleoside reverse transcriptase inhibitors, together with an NRTI, or a PI, or an integrase inhibitor. Dual NRTI combinations are usually emtricitabine or lamivudine, so they have the same mechanism of action and so are never combined together with one of abacavir, tenofovir, or zidovudine. So we can give lamivudine plus zidovudine plus nevirapine, or we can give amitriptyline plus abacavir plus rilpivir, etc. This sort of ART regimen can be used. So when do we start ART? So WHO guidelines now recommend starting ART in all people with confirmed HIV infection irrespective of the CD4 count. So we no longer look at the CD4 count to start ART. We give ART to everybody suffering from HIV. So about a short bit about the post-exposure prophylaxis. For example, you are working in a hospital and suddenly you get a needle stick injury from a syringe which has been suspected of HIV, or which has been used in a HIV patient. So what do we do? So post-exposure prophylaxis is recommended when the risk is deemed to be significant after a careful risk assessment. So first we do a risk assessment in both occupational and non-occupational settings. So this dose should be given as soon as possible, usually within the 6 to 8 hours. There is no point in starting post-exposure prophylaxis after 72 hours. And tenofovir together with amitriptyline is the most widely used dual NRTI combination together with the PI. So we give the same therapy we gave earlier, but PEP should not be given if the exposed person is HIV infected. And after 3 months of exposure and 3 months of this therapy, we'll do a HIV antibody testing. And if it's positive, we'll do the same therapy we use in HIV positive patients, or we'll discontinue if the antibody testing is negative. So this is post-exposure prophylaxis. So please subscribe and comment in the comment section about what videos you want to see next. Thank you for your support. I hope this video has been useful.